Well, I think we already have shown in multiple studies now with 3 different drugs in class, although the data on the abemaciclib is a little bit delayed compared to the ribociclib and the palbociclib, but we can clearly show that we can delay progression in metastatic breast cancer quite dramatically. The question is going to be, one, do these drugs improve overall survival? That's important because these drugs are not cheap as chips. You want to persuade people to use these drugs, and the easiest way to persuade people to use these drugs is to say, you will live longer if you do this, as opposed to your disease will be controlled a little bit longer with this particular regimen, but you won't live longer. Right? So the first impact statement is, we don't know yet what the full impact of these drugs are. The trials are too immature. And of course the second question is, will they improve outcomes in the early disease setting? Well, that's a more complicated thing, right? Because you've got patients who with ER-positive disease, many of whom are going to do fine anyway with the current standard of care. And so you have to do trials to expose a lot of patients to these drugs that theoretically don't need them. And so we really are going to have to look very, very carefully at the design and subset analyses within the large adjuvant trials that are ongoing. I definitely think there's lots of patients that will not need CDK4/6 inhibitors. We got lots of nice genomic models and maybe this neoadjuvant model to tell us we have patients whose 10-year relapse-free survival is about 96 to 97%. So just as they couldn't possibly benefit from chemotherapy, they couldn't possibly benefit from a CDK4i.